Hello, this is Ryan De La Torre. I'm an attorney with the California Department of Insurance, and I'm going to give you an overview of two reference documents, which will hopefully help to inform your ideas about which types of long-term care programs you'd like to investigate as part of the task force. After watching this video and hopefully reading through the documents, if you could please complete the questionnaire that's available to you, we would very much appreciate it. The first document that I'm going to cover is will address program structure concepts, public, private, and hybrid solutions. The idea with this document is to give you a general overview of the landscape of public, private, and hybrid ideas that are out there for how to address some of our issues in financing long-term care through long-term care insurance or other types of programs. In terms of public benefits, that can include universal social assistance, vested social insurance, or targeted social assistance. Private solutions in this context would refer to some sort of program that provides public support for private market solutions. A hybrid solution would be some blending of the two, uh, so a public benefit that is designed to coexist with some private insurance component. There's a good amount of information on the document, so I'm not going to cover everything. So again, if you can, please read through it on your own. The document first covers public benefit options, then covers some private, uh, private some programs that would help to promote private solutions, and then it will go over what a hybrid would look like, a hybrid solution would look like. In the left-hand column, it lists examples of these types of ideas. There's also questions, pros and cons for each example or for each category, which will hopefully help to identify some of the issues that you'd want to think through if you're investigating that type of program. First, under public benefit options, we have universal assistance. Universal assistance would provide a benefit for everyone who is in need of long-term care. Uh, this types of universal program exists in Denmark, France, Japan, Germany, the Netherlands, Singapore. So internationally, it's somewhat of a standard among advanced economies. In the United States, it would be a new thing and very much so on the state level. Maine had a ballot initiative in 2018 for a universal home care program that was rejected in the 2018 ballot. Interestingly, a good number of long-term care provider organizations came out against the initiative, which was a pretty significant factor in why the initiative was rejected. Universal program would be a big change. It'd be a very new thing for the United States. So there's some pretty big questions about how that would work. Maybe chiefly among them, one wonders how whether this would work effectively at the state level. For example, uh, would we see a significant number of retirees move into the state to take advantage of the program? And if so, what would that mean for program costs and program sustainability? Another big question is interaction with Medicaid. In California's case, Medi-Cal. The federal government provides about $60 billion annually to California to through the federal contribution towards the Medi-Cal program. So if a universal program were to overlap with Medi-Cal to some significant extent, and Medi-Cal usage is as a result reduced, would that result in a reduction in federal funding for California? Our next category is vested social insurance. A vested program provides benefits to individuals who vest into the program. Usually that means a worker who has paid a payroll tax for a certain amount of years, and after they reach that requisite number of years of paying into the program, then they qualify. And once they, if after they do vest and they have a need for long-term care, then they would receive program benefits. The most recent example of that is the Washington Trust Act, which we covered in depth at the last task force meeting. Another famous example is the Class Act, which was a voluntary long-term care insurance program which passed as part of the ACA, but it was never implemented and was repealed due to concerns about adverse selection, high premiums, and program sustainability. Um, the voluntary nature of that program turned out to be a fatal flaw. Third category would be targeted social assistance. So this would be a public benefit which is designed to help out a target population or to fulfill a target purpose. Um, there are programs out there, for example, that help that are targeted to unpaid family caregivers. In Hawaii, there's the Hawaii Kapuna Caregivers Program, which provides $350 per week to unpaid family caregivers that meet certain conditions. Another potential targeted program would be one that provides additional benefits or to individuals with Alzheimer's disease and who have a need for long-term care. Uh, that's a potential idea because Alzheimer's disease usually comes with requires quite a bit of long-term care and can cause those individuals to have very uh, very uh, very large, very significant long-term care costs. And if one were to target a specific purpose, for example, you could attempt to help seniors to age in place by creating a program that funds transportation services for the elderly, food services, adult daycare, and other types of services that would help the senior population to age in place. As for ideas for that would help to promote private market solutions, one example idea that's out there is a public-private reinsurance pool or some form of risk sharing between for private long-term care insurance carriers. The idea is that if you are able to reduce some of the risk that long-term care insurance carriers incur when they sell new long-term care insurance policies, then those carriers will be able to sell those policies for cheaper and more people will, as a result, buy long-term care insurance. Milliman looked into this idea for the state of Michigan and found that a reinsurance program would have limited potential to increase long-term care insurance sales. So their conclusion was not particularly positive in that feasibility study. Another idea is to help the private industry to develop new uh, new products, new types of private long-term care insurance, with the idea that these new products might prove more attractive to the market or more affordable, and as a result, increase long-term care sales, long-term care insurance sales. Minnesota is looking into doing that by helping to develop a term life policy that converts to long-term care insurance at a certain age. So the state's role in that would be to help um, help look into kind of actuarial modeling for that sort of product and doing some marketing research to see if there would be interest in that kind of product. And if necessary, passing legislation that would either make the product legal or to help facilitate its sales. Another idea that has been proposed is to require Medicare supplement health plans to include a limited long-term care benefit. This is another Minnesota proposal, and it would require med-sub plans to include a non-medical long-term care LTSS benefit package. There are some concerns that making this a requirement would make med-sub plans non-actuarially or actuarially non-viable, or could cause the price of those plans to spike. And another category of proposals that's consistently on the table is ideas to expand um, partnership options, or to otherwise find ways to increase sales of partnership policies. We talked about those partnership policies in a little bit um, in our task force meeting last week. And then our third category of ideas, hybrid public-private solutions. Essentially, you could either have you can have private long-term care. If you have a public benefit, there's going to be gaps in coverage. Either the public benefit might have a lifetime limit, so once the individual has exhausted the public benefit, then they would need some other source of funding to pay for the long-term care. So you could have private insurance that kicks in after the public benefit is exhausted. You could, if the public benefit had a waiting period, on the other hand, if the public benefit only started after, let's say, 3 years, you could then private insurance would supplement on the front end. You could have a private insurance product that paid out for 1 or 2 years during that waiting period, and then that would allow the individual to preserve their assets before the public benefit kicked in year 3 or 2 or 3. Another option is for private insurance to offer complementary coverage. So that would be covering copays, share of costs, or deductibles if the public benefit were to include any of those costs. And you see these private, supplemental, and complementary insurance options in a lot of the systems internationally, and a lot of the countries internationally that have universal long-term care insurance programs. This next document will cover program coverage concepts, front end, back end, or comprehensive coverage. So this document really kind of lays out the way that coverage can be oriented. Coverage can either be provided on the front end, so soon after the individual has a need for long-term care. Coverage could alternatively be provided on the back end after a defined waiting period of 1, 2, 3, 4, 5 years. Or you could have a benefit that's comprehensive and covers both front end and back end costs. Obviously, from the individual's perspective, comprehensive is ideal, but that's going to be the most costly. But comparing front end to back end, you could say that front end helps more people, but provides fewer benefits to each person. A back end benefit, on the other hand, helps fewer people, but is likely to provide more benefits to each person that receives them. And the reason for that is just because since the back end design has a waiting period, so it's only going to start paying out after 2 or 3 or 4 years. About 50% of long-term care claims end within the first 2 years. So a lot of people aren't going to still need that long-term care by the time that the waiting period uh, is is completed. So they'll never receive payments under the back-end benefit. And so if you have equivalent funding between a front-end program and a back-end program, since you have fewer people receiving benefits under that back end, then they can receive greater payouts or for a longer period of time. So front end may be a bit more egalitarian. If you pay into the program, or if you qualify for the program, and you have a need for long-term care, you have a very high likelihood of receiving some sort of payment. Back-end program is going to be targeted more for those people who have longer, more costly claims. so a bit more targeted on towards that needy population. Example of a front-end benefit is the Washington Trust Act. It pays out $100 a day for 365 days, and after that, the benefit is exhausted. And one thing to keep in mind when kind of considering front end versus back end coverage design is interaction with Medicaid, for example, and you'd also want to consider interaction with private long-term care insurance. Front-end design probably will have less overlap with Medicaid because Medicaid only kicks in after an individual's assets are exhausted. So it's kind of a back-end sort of design. There's a little bit of, unless the individual has no assets, there's going to be a period of time when the individual spends down before they can go on Medicaid. So that front end benefit is going to kick in quickly. So it's going to be kind of more oriented towards the front end, whereas Medi-Cal will pay towards the back end. So there's a bit less overlap. Private insurance would supplement a front end benefit by paying out benefits after the public benefit is exhausted. So that public benefit would somewhat act as a waiting period for the private insurance. And hopefully, theoretically, that could allow for some private insurance designs, supplementary private insurance designs that are cheaper than some of the private insurance policies that are existing in the marketplace currently. Example of a back-end design is the WISH Act. This is a new proposal. I think it's Senator Susi. I'm not sure if I'm pronouncing that correctly, but it would be a federal catastrophic long-term care insurance program. There would be a waiting period of 1 to 5 years, depending on the individual's income level. So if lower income individuals would, they would have a shorter waiting period of 1 year. And then that waiting period would gradually ramp up to as long as 5 years for individuals who have higher income. And so again, that's something that would be a benefit targeted towards the more needy. So there's some kind of need-based targeting going on in that sort of design. In terms of interaction with Medicaid, a back-end design would have a good amount of overlap, so it's something to consider. It would work well with supplementary private long-term care insurance. Long-term care insurance carriers could offer private policies that covered that waiting period, right? So if the public benefit had a 2-year waiting period, private long-term care insurance carriers would likely come out with products that were designed to cover the individual's long-term care expenses during that 2-year waiting period, and that would be a pretty efficient interaction between the two. And then a comprehensive program would cover, again, both front-end costs and back-end costs. And you see comprehensive designs in some of those countries that have adopted universal assistance programs, such as Denmark, France, Japan, Germany, the Netherlands, and Singapore. So again, please please read over these documents in a little more detail when you have the time, and please remember to fill out the questionnaire. Thank you very much.